Welcome everybody to our afternoon webinar from the RASopathies network. I'm glad you all could make it. RASopathies are a group of genetic syndromes caused by mutations in genes that code for components of the RAS, RAF, MEK, ERK cellular signaling pathway. Individually, the RASopathies are considered rare diseases, but together they're among the most common group of congenital neurodevelopmental genetic syndromes. And because all of these genes and gene variants occur in various members of this pathway, and they affect the pathway similarly, meaning they overactivate or they unregulate the pathway, this leads to the similarities that we see in the traits of individuals that have these different syndromes. But as you may know, the features and the severity of those features can vary widely. So we're here today on behalf of RASopathies Network. We're a nonprofit research advocacy organization powered by passionate volunteers. And our mission is to advance research to improve the quality of life for RASopathies families by bringing together clinicians, scientists, and families involved with these rare disorders. Here are our passionate volunteers, AKA our board of directors, Lisa Scheuer and Lee Johnson, Kim Connor, me, Beth Stronach, Colin is Bruce's son, Bruce Deckman, and Kara Borian. So how do we advance research? Well, we really have two major activities that we participate in. One is to hold biennial scientific symposia. So you can see we've been doing this for over 10 years in different locations. And we really just try to bring all interested parties together in one room to share new issues that arise and new results and evidence that's coming out from important studies. And basically, this helps to facilitate collaboration, make people excited about the problem and sort of re-engage and share in the urgency. And together, this leads to hopefully a synergy in this collaborative environment. The other major activity that we do is to fund research. And so the activity that we primarily do this through is the $1 Million Bike Ride. And it's upcoming in about a month in Philadelphia. The University of Pennsylvania School of Medicine and the Orphan Disease Center provides the infrastructure and the ability to solicit and review grants or proposals for research activities. And there's a lot of different rare disease groups that ride in this bike ride and fundraise for their organizations. So the RASopathies Network riders are going to be riding again this year. We support research projects on Costello syndrome, CFC syndrome, Noonan, and Noonan-related syndromes. And every donation that comes in, RASopathies Network will match 1-to-1, and then the Penn Orphan Disease Center will match again up to $30,000. So really you're quadrupling your donations. So if you're interested in participating or donating, please contact us. We would love to include you. And so over the years, we've supported 10 different research projects with pilot funding. And these, as you can see, cover really a wide range of different topics, from looking for novel therapeutic leads and testing therapeutic interventions, more specifically looking at issues in the RASopathies community that have been raised, like pain, gastrointestinal problems, hypertrophic cardiomyopathy, and the lymphatic system. This past year, we raised $60,000, a little more than that, to fund a project called the SOAR study, which will be getting ready soon to start recruiting. This is social outcomes in adults with RASopathies. So with that, I will say thank you for your attention and listening to my presentation. And I will now get to the main event, which we are really delighted to have with us two incredible people. The world-renowned investigator and clinician, Dr. Petra Klinge, who's a professor of neurosurgery at the Warren Alpert School of Medicine at Brown University. And also Patricia Welton, who is a patient advocate, the CEO and founder of Beyond the Diagnosis, which really is an amazing organization that, well, hopefully she can tell you a little bit more about it, but it provides a traveling art exhibit that unites art and science to raise awareness and educate individuals on research and innovation of treatments for people with rare diseases. So we're just absolutely thrilled that you could make it today and to tell us a little bit about tethered cord and whether there may be implications for the RASopathies. Okay, so now I will stop sharing my screen and I'll allow you to share yours.
Great day. Good afternoon, everyone. It's a great honor and pleasure to talk on this occasion today about tethered cord and potential implications. I certainly will have my talk focus mainly on the understanding of tethered cord that we have so far, and also what we have researched so far, and then certainly some suggestion about what can be done. Quick question, do you see my screen okay?
Yes, we do.
Okay, awesome. Excuse me. So that might be one of the important or most important slides showing when exactly and at what week of gestation tethered cord occurs. It's basically between the 6 weeks and latest 10 weeks of gestation. So in the first trimester and pretty early. What happens is at the 6 weeks we form, and you can see it here on the right side, we form our neural tube from the ectoderm, which is the outer layer of the embryonic 3 layers. And then there's a caudal extension to the neural tube, which is the spinal or embryonic spinal cord, which then with that we grow our legs. And then at around 9 to 10 weeks, these caudal neural tube will regress or decrease in size due to cell necrosis. So these cell necrosis is basically a programmed cell death of the caudal spinal cord. And then this remaining spinal cord basically will be the phylum terminale. And that is basically the structure that will remain in our spinal canal from that. This phylum terminale, as I said, forms very early and is then at the end, a little, you see to the left here, a little, fibrous tissue. And I have shown here a histological picture of a phylum from a cadaver, how it looks like. It's basically basically just like a fibrous and vascular band that connects the tip of the spinal cord, which is the conus, with the dural sac at the tailbone. That was once embryonic spinal cord that was active between the 6th and 10th embryonic week. And then when we are kind of born, you can see here on the right side, the phylum holds the spinal cord in the spinal canal. And as we mature, the phylum kind of allows the spinal cord to maintain a level at the L1, L2 spinous vertebral level. So that's the normal level of the spinal cord, which levels out after the phylum has kind of gained its matured extent. So I always explain people that this is basically our congenital tail. You can also call it an appendix of the spinal cord, but it's a little unfair because we should not forget, and that has also implications, that the phylum still has some role in maintaining the cushioning to the spinal cord, as well as controlling the spinal cord motion within the spinal canal. So a little bit of an anchor, but not just an anchor. So if something goes wrong in the phylum terminale formation, which is basically embryonically the failure of the retrogressive differentiation, then we have either a short phylum, as you can see here in the left, that doesn't let the spinal cord to level at its appropriate terminus, and also the phylum can be thickened or can have all abnormal cell tissue from embryonic leftover events. For example, you can see here, this is an abnormal phylum. You can see fat in the phylum. These are histological pictures actually from patients. You can see abnormal blood vessels in the phylum here on the very right. And on the bottom, actually very interesting, you see ependymal cells. Ependymal cells are brain ventricle cells from the brain ventricles. And they are supposed to reside in the embryonic phylum, but not anymore in the adult phylum. So if they reside there, this is abnormal, and they can actually can contain spinal fluid, and that actually also can aggravate the pressure in the spinal cord and cause all sorts of symptoms. So basically the phylum is structurally abnormal. And I just wanted to share with you, just so you have an understanding, we talk about it a little bit later, that this is how the phylum looks like, though this is a picture of an abnormal phylum, actually in a surgical patient. Bear with me, what you see is basically the spinal canal. And you can see here the nerves, these yellow and red structures. And then in the middle, you see this little white yellowish piece. This is the phylum. But this is a very thickened phylum. Just for your reference, the phylum should be smaller than a nerve. Look at these spaghettis here. Forgive my language, but I think this is gives you a good understanding. And then the phylum should be smaller as any one of these other nerve structures. So what is very important, and that also basically, I think where I can help today is to help screen for tethered cord and to help you understand that tethered cord truly, even in the most complex clinical scenario, has biomarkers and has clinical indicators. And that is my main message. We certainly can talk about research also, but research is to be done, and hopefully we can write the book here. So there are first of all, there are, besides imaging, we talk about that, and besides looking at a child and looking at the patient, the symptoms, we were talking about that, there are also what we call neurocutaneous signs. Not everyone with tethered cord has them, but as Patricia Welton knows very well, and we both have looked at it, the incidence of like a sacral mark on your butt at your bottom is very important to kind of establish and also further lead into looking at the diagnosis and taking it very seriously. For example, here, just an example like a deep dimple, and then some kids, just gonna move my, some kids also have like a, on the right here, like an asymmetric gluteal cleft. Some have like a little discoloration at the buttock. So there are all sorts of signs that one should look at. And I'm just saying, those don't go away when you're adult. So we also see adults with tethered cord syndrome, and we then sometimes, you know, look at this in the adults to get some traces from that. Briefly, the imaging, though it's not brief. As I told you, our spinal cord is supposed to end somewhere if the phylum has its normal capacity. As I said, usually at 6 months of life, it can be still at the L2, L3 level. This is a lumbar spine MRI. I'm sure you're familiar with this. You count from the bottom, 5, 4, 3, 2, 1, here on the left. When you are older, the spinal cord should level at the thoracic 12 or lumbar 1, 2 level. And then also, usually the phylum, like in I would say 90% of people should not be seen on the MRI. I just told you it's smaller than a nerve. So I intended to name my slide not imaging findings of the cord, because sometimes there are not a lot of findings, and that sometimes makes it complicated. So often we get the report, see here on the left, normal vertebral complement, normal alignment, the vertebral normal shape, and then here normal conus and termination at L1, no fibrofatty thickening of the phylum, normal cauda equina, and that is more or less eyeballing the MRI. So if we really want to scrutinize, and that is also for our education or your education, we truly have to look deeper. So usually we scrutinize the MRI, look at very subtle signs of a thickening of the phylum here. And you cannot only do it by looking at the side view of the MRI, you truly also have to look at the cuts of the MRI. So we have the sagittal and the axial cuts. For example, here, it's tiny, but I wanted to introduce to you how really thorough one has to be to look at this. For example, here is a MRI, I'm on the left, where you can see the spinal cord, this gray line centered here. These are the vertebrae. And then there is a axial cut somewhere here where the phylum is supposed to be. And then you can see here a little white dot. It's very tiny, but that is a thickened fatty phylum. You might say, wow, but yes, that's how thorough you have to be. For example, then also with the level of the phylum. Here, of course, it's very obvious. This is the end of the level of the spinal cord. This is the end of the spinal cord. Here you can count like L5, L4, L3, then that is obvious. But look at the next slide in the middle where it says L5. So here, for example, it is a little bit controversial. What is L5? And we discussed it on Friday when we had our little pre-meeting, that it is very important to consider also abnormal vertebra in the counting. For example, people would say the vertebra below where I put my L5 might be L5 because it still has a disc and the rest is the tailbone, but it's not. This is a transitional vertebra, so you would count from the level, from the vertebra above. And then this phylum also ends at L3, noticing the tip of the conus. So you have to be very mindful of the anatomical circumstances. Sometimes you see an X-ray, the very right, that has like unfused lamina of the vertebra, which can be also a sign of indirect abnormal or indirect signs of abnormal phylum. You truly have to look at indirect signs. And then also some people with tethered cord have like a syrinx or a terminal ventricle, which is fluid in the spinal cord. White is fluid here on the very last picture. This is also a sign of an abnormal phylum. And if you see just that, you already should be suspicious that this is here a situation of tethered cord, even if you don't see the phylum, even if the conus of the spinal cord is at the normal level, this raises suspicion. Of course, sometimes not even those signs are present. And you have the MRI totally occult, where the conus is at the normal level and you don't see the phylum. Then you still have to trust the syndrome. We're going to talk about that in the next 5 minutes. I only want to mention if the imaging is occult and you have all these symptoms, you just have to make sure that you get a full MRI of the spine to rule out other causes that can potentially cause the symptoms. So you want to rule out lesions in the spinal cord or any stenotic situation. So you have to have a clean slate of the MRI so that nothing else explains what is going on. This is my sign for occult in disguise. So talking about the syndrome, we have a triad that is consistent of neurologic triad, I'm sure you're familiar with this, but let me just say it, is a complex of symptoms. And triad means three hallmark symptoms that if they are coming together, they make a real good cause that this is the condition. We have the neurological findings, we have urinary symptoms, and orthopedic or skeletal symptoms. The neurological findings, very important, vary with age. Infants, for example, have more decreased leg movement, absent reflexes. Toddlers show with abnormal or delayed walking. Teenagers have these growing pains, which often is tethered cord pain, or asymmetrical leg weakness with exercise. And then the younger adults, unfortunately, with some stress to the spinal cord, start with spasticity and increased tone and spastic abnormalities. The urinary is often frequency, urgency, retention. I have some other slides about that. And then very important, because I know this is often the problem in often in a lot of syndromic situation, are the skeletal abnormalities, the scoliosis or delayed growth, joint subluxation, for example, EDS, or abnormalities of the foot. You know that way better than I. And here it can sometimes be tough to figure that out. Though I'd like to say is if a triad can somehow just kind of be shaped in how a person presents, then we can start to put things on the ground. So this is a very busy slide. I don't want to spend long on this, but I just want to let you know. So in the year 2012, we started to see, well, what are the top symptoms of tethered cord? And can we find out what are the most telling symptoms and signs? So we started, don't want to spend too much time, to look at a bunch of symptoms. So all the symptoms that the patients that saw us for tethered cord had started to report. And you can see here, like bowel, constipation, urinary, and then also neurological complaints, leg fatigue, leg weakness, cramps, curling toes, falling, tripping, headaches, even tinnitus. And then our neurological findings that the doctor's finding, hyperreflexia, tremors, weakness, touch deficit, and then of course the orthopedic findings, scoliosis, kyphosis, foot deviation, and then also the neurocutaneous sign. And then we did like a factor analysis and logistic regression analysis. So a lot of statistics, which then led us to a scale that now allows us basically to grade the certainty of tethered cord. Almost like, how can I say it, like the Beighton score, where you grade a certain number and then this raises the suspicion for example, a connective tissue disorder. Very important biomarker in the neurological exam are these three things. It's increased leg tone, remind you, often asymmetric, often more in the leg, where you see more complaints. Let's say you say, oh, my kid starts to limp or turns the foot in more on the right side, then that's where you always get your exam abnormal, or the abnormal exam. Often the lower extremity reflexes are hyper and the upper extremities are not as hyper. You see a clonus, which is like when you move the foot up and down, you see like the little beating of the, or tremor of the foot. So of course, this is a very professional exam, but we have found out that we see this exam again and again in people that most typically present with tethered cord syndrome. And this exam is a sign of the dysfunction of the upper motor neurons, which is not a surprise if you think of a phylum, an abnormal phylum causing stress and strain to the spinal cord. Those motor neurons are challenged, and that's why it's likely upper motor neuron dysfunction and not a peripheral nerve dysfunction. So very important. And then of course the conus dysfunction, which is the bladder abnormality. Of course, sometimes if you need more certainty and if you can, not everyone is eligible to have that. Not eligible, I should say. Not everyone would be able to do this exam. Sometimes urologists, certainly in young kids, say it's not validating because you can only do it in sedation. So not everyone can do urodynamic study. There are also certain limitations, and it is still an invasive study. But sometimes it is needed. It is very reasonable to support the diagnosis. So you have to very thoroughly assess who should be having it and establish a medical indication for a urodynamic study. In our research, we certainly tried to get as many urodynamic information as we could, because we also wanted to establish urological criteria. And in our people that we studied during our clinical care, 50% had the dyssynergia between the sphincter detrusor and between the sphincter and the detrusor. Some people had increased bladder capacity or incomplete emptying due to decreased sensation. Sometimes people had like an increased bladder capacity and incomplete emptying. So it's not like just one finding in the bladder study, but these were the most important. I told you that we were trying to find criteria to establish the most important diagnostic biomarker. And this just recently has been published after many years of work, kind of 10 years of work. The clinical criteria for the resection of the phylum terminale. I'm not sure that gets me into the web page, but as you, and I don't want to, so this is, in the interest of time, this is open access. So if you type in Petra Klinge and then OTCS, or you can certainly share my slides. If you click on that link, you get directly to the page where you can download the PDF. And that publication has basically what I'm showing here is we are based on that big questionnaire that I just showed you earlier, where we assembled all these symptoms and signs meticulously, shows the top 5 basically in each category of the triad. For example, neurologically, again, this is the what the doctor find and what people complain neurologically, the top 5. Why do we call them the top 5? Because the majority of patients have them, so a high number. And you can see here the doctor finds increased muscle tone in the legs, often asymmetric, as I told you, hyperreflexia in the legs, and foot clonus. Patients report fatigue and leg paresthesias. And then, of course, the pain scale is leg and sacral pain, lower back pain, cramps in the leg and backs, often at night. And symptoms often fluctuate. You have a good day, you have a bad day. Then it's one leg, sometimes the week after it's the other leg. So it's not always confined to one leg, but it usually is the entire leg. And it's never like a certain point where they always say, oh, it's always running down to my little toe, or it's always running into my medial aspect of my thigh. It's fluctuating. It affects often the entire leg or certain parts of the leg. So it's not really like a distinct pattern. So that's what is so puzzling. And that's also what doctors struggle with, because they then think, well, how is that explained by anything if symptoms are so fluctuating and so nondescript? But they are nondescript because it affects the spinal cord. And the spinal cord is a very delicate structure, and there are no rules which part of the spinal cord is affected. So different parts of the spinal cord are affected randomly based on the dynamics of the day, so to speak, which is serious. And then, of course, the continence, the top 5 were bladder leakage, urgency, frequency, hesitation, and then bowel symptoms, which is both constipation and bowel incontinence. Certainly, you would say, you know, like, well, if you have a nonverbal person, you know, or a person that has a high pain tolerance, we have certainly limitations on using the scale. I see that, but we still have a good bunch of biomarkers, and you see later in our predictive panel, we have shown that if you have 6 out of 15 of these, you are already having a good stand with surgical intervention, or at least establishing the diagnosis. So therapy and surgical intervention. So physical therapy is certainly the first line of treatment. You should give it a chance of medical and physical therapy to see whether you can alleviate the stress to the spine, and through ligamentous relaxation can also alleviate stress on the dura, where the phylum connects to, or pelvic floor therapy for the bladder function. But if those measures fail for over a period of, let's say, 6 months or even a year, it is reasonable to consider surgery. This is just our surgical decision-making. I showed you the surgical criteria. Then, of course, you have to look at the comorbidities and embrace syndromic conditions. That is certainly, you know, what we all understand here. And next to the Ehlers-Danlos syndrome, Bechtel syndrome, and other conditions. Tricia Welton and I, in the meantime, with others, have worked on the KBG syndrome and its prevalence in tethered cord. And if there's progression, then surgical section is reasonable. Also, in my slide, and you can share that, is a link to a little video that shows the resection of the phylum terminale. We assess the phylum terminale through a small interspinous process approach, like a translaminar approach, where basically almost through the little spinous processes, you approach via microsurgical means. With a surgical microscope, you open the dura and you identify the phylum, as I have shown you in the other picture. So the follow-up, so the results are quite encouraging. We have shown that, remember the items, the neurological criteria, the continence criteria, the pain criteria, and then the whole scale. We have looked at the changes after 3 months and after 1 year. So the visit 2 is changes after 3 months, and the visit 3 is after 1 year. And you can see here the majority, so a high score on the scale shows you are heavily affected by neurological symptoms. So see the drop after 3 months. Also see the drop in continence after 3 months. So great improvement in the amount of urological and neurological symptoms. Also pain improvement, and here's a change in the whole scale. It looks a little bit more different at the 1 year mark, though the neurological symptoms are still way better, like leg fatigue, leg spasticity, as well as leg weakness. Incontinence also still better, but some symptoms come back. And the pain is the most difficult symptoms to treat, though I have to say in our research, we're still looking at a better pain scale for tethered cord. And it might be, the study might be biased because we just have not found the correct or the best pain scale for tethered cord, because I just told you the pain is sacral, back, leg, and also often it is pain that is very difficult to describe, and none of the existing pain scales that spine surgeons use applies to tethered cord. So that is where we were a little bit left with nothing much out there. So we
Could I
had
ask
our
something
own...
about the pain scale?
Yes, please.
Because are most of the patients in this study Ehlers-Danlos syndrome?
Yes, that is true.
So when I was reading your research, when it got to the pain scale, you know, I wondered to myself, because the pain can radiate, you know, from the joints and other parts of the body with Ehlers-Danlos syndrome, if the, like, how you measured the pain Like it must have been really difficult to determine with an EDSer, you know,
Absolutely.
the pain wasn't due to the hips or a lower rib or anything, you know, with EDS, inflammation of some kind that wasn't related to the tethered cord. So I wasn't sure if that's why that went up, because it was mostly EDS patients and
Yes, and you're so right, Patricia. That is a very good comment. And that was also kind of because our question was mainly, do you still have significant pain? You know,
Yes.
and that was not a very, very good way to do it. But at the time, we didn't have anything else. So basically, it was not really differentiating between, you know, like connective tissue pain and real neurological pain. Correct.
Right.
And that's
Okay.
where we are still kind of looking into things.
I don't even know how you would do that, but
Yeah, good point. I guess I need some more sleepless nights to figure that out.
Yes.
So real quick, because now that Patricia is on, just so as I told you earlier, we did like some predictive analysis, and you can see here the score 7 out of 15 already gives you a chance of 60% of improvement from the surgery. So not too bad, and certainly encouraging. And certainly, when you talk about surgery, we always hear here are, you know, complications, spinal fluid leak, infection, and wound issues. I don't want to belittle those, and they're certainly, you know, technique has to be pioneered and always challenged. And can we do better? This is just like our patients. In the meantime, quite a good number where gladly the spinal fluid leak is not as high of a complication. We are mainly dealing with wound problems, as you can see here, but all, you know, like are still in the range, you know, the leak and CSF complications are in the range of 1%. And then also others are, you know, like not as significant. Arachnoiditis, 3%, like the scar that can develop after the surgery. The need for reoperation looks like quite high, but that does not include, that includes like wound revisions, washouts for infection, some retethering, and also skin repair. So
what's the age range on this particular table?
We have all sorts of like 1 year or younger than 1 year to 83.
Okay.
So all ages. And it's true, it's a good question. I appreciate it, because we didn't really separate out what confounding factor could be here, because there might be a certain population that are at higher risk for that, and that was not singled out. Real quick, my last slides just show that we also looked at what is it that causes the symptoms. Hey, we have an occult tethered cord. I just pondered on the fact that more often than not, probably the problem of tethered cord is not even seen in the MRI. And we wanted to understand, why can that be that such a phylum that is so minute of a structure in the spinal canal and might only minimally be pathological could cause this significant spectrum of symptoms. And we did some mechanistic studies together with histopathological studies on the surgical specimen. So this is on the right here. You basically see we did that together with the bioengineering lab at Brown University. We sent our surgical specimen, of course, IRB approved and with patients' consent, for both minors and adults. It's a mixed population that went into this study, and they did stress and strain tests. And what you see here, that, you know, so this is certainly unprecedented. No one has ever done these tests in any neurological tissue, let alone a phylum. But these studies of stress and strain have largely been applied to joint tendons, like like patella joints, tendons, and elbow tendons. And those guys have found out that usually the stress that you apply and the strain that a structure can accept is linear. And then at very high forces, the ligament or the tendon ruptures. And we have seen here with our tests that you see here like stresses up to 8%, or strains up to 8%. You can see here that in tethered cord in hypermobile EDS, already like strains at 5% cause the phylum now to, or the structure, which is a phylum here, to lose its structure and to break and to lose its strain profile. So a failure of biodynamic capacity to hold the spinal cords in a dynamic property. And that was likely due to microdamage of the collagen fibrils, which certainly in Ehlers-Danlos wouldn't be a big surprise, because we have to assume that collagen deficiency is everywhere, even in the phylum, which also has collagen, but no one has shown it before. And we show here, this is the phylums of people with Ehlers-Danlos. We show disintegration of the fibrils, also disheveled fibrils, corkscrew-like deformities of the fibrils, which shouldn't be like this. This is a collagen fibril in its normal shape. You see well-aligned and well-organized in a different pattern. And this is a normal collagen of a normal cadaver phylum, and this is a collagen abnormality in the phylum. We also found inflammatory cells, indicating that basically the phylum is maybe even a tendon of the spinal cord, because it undergoes microdamage and inflammatory changes, almost like an overused tendon. So we have a mechanically challenged structure here. This is certainly a concept that needs further understanding, but it shows that basically this is not anything that ever imaging will allow us to show. If we believe in the symptoms and believe in the concept, then here we have an explanation what the phylum does and what it doesn't do if it fails, and why it might cause such a number of challenging and disabling symptoms, because the phylum would not absorb the shock anymore, because it loses a stress strain capacity, and all the shocks of any impact, maybe just sitting down, go directly to the spinal cord. This is just showing a car with the lost shock absorber, gives you a bumpy ride. Patricia and others, including Annette Mogan, the CEO and co-founder of the KBG Foundation, we have already shown the prevalence of tethered cord in the KBG population. So what does it imply for RASopathies? Well, the phylum problem happens early in gestation, a process that is certainly vulnerable to any genetic mutation, because it's in the germinomic period. So it's got to be a connection, and also would suggest that there's a high prevalence of tethered cord in in genetic conditions. Certainly, like I said, it's difficult to find out whether tethered. It's not that difficult. We have biomarkers that helps us to understand whether or whether not, even in a complex condition or complex clinical scenario, whether or whether not tethered cord should be considered. We have the biomarkers, increased tone, hyperreflexia, and clonus, and some sort of triad that can be established when listening and looking at the situation very closely and thoroughly. And the outcome is promising. However, more research is needed to certainly look at other surgical indications, specifically in other genetic syndromes. Thank you for your attention.
Thank you very much. Before we open it up, I thought I may reshare my screen just to put up the survey. I know you guys, and we can talk about it as well. Patricia and Dr. Klinge, you had suggested that if people are experiencing this in the RASopathies community, you'd be interested in learning more. And so we've been sharing this survey with our community, and we hope that other people will, that additional people will fill this out. So I want to maybe leave this up here for a minute or two. And perhaps, Patricia, you might want to add a little bit to the story, or...
Sure. Why am I here?
Yeah, tell us, please.
Well, how did I end up here? So my name is Patricia Welton. Both of my kids have Ehlers-Danlos syndrome. My oldest daughter, Olivia, had a tethered spinal cord, and her wonderful neurosurgeon was Dr. Klinge. And I'm sorry, Petra, but my daughter was, of course, not like anything that we just saw. My daughter was a tennis player. She was a Division I tennis player at the time. She had no pain. She did have the cutaneous finding. She was born with a very deep sacral dimple. They did an ultrasound, and they said it was closed. It didn't mean anything. But as she grew, she developed scoliosis. So her orthopedist, recommended bracing, and we did everything that we should, and then some. And her scoliosis got to 41 degrees, and they wanted to put in the Harrington rods. And I said, there's something going on with that dimple. That means something. Can we, look into that? And then he referred us to Dr. Klinge. And thankfully, my daughter, it was clear. She had a low-lying conus. They could see it on the MRI. It wasn't, she didn't need, it was obvious. So thankfully, we didn't do the Harrington rods, and Dr. Klinge did her the dissection, and then Olivia went on to play Division I tennis again. She, her EDS, a lot of times EDS around the symptoms get really bad during puberty or hormonal changes. And that's when my kids really fell apart. So they don't play tennis anymore. But, a lot of her symptoms, she had severe constipation, and the scoliosis, I don't think changed even a degree after she had the surgery. So I'm here because I work in all rare diseases. I run an art exhibit, and we do portraits of children with rare diseases that travel around the world. But I also put together a catalog, and I learn a lot about the diseases that, we have to put this book together where I'm actually reading all about these diseases. And I'm like, wait a minute, there seems to be a lot of symptoms of tethered cord out there. And then on Facebook, and there's some people that share a lot. And thank God, Annette shared about her son who has KBG syndrome, and she shared a picture of his feet, and they were going to get his Achilles tendons cut because they were tight. And I knew that was a sign of a tethered cord. So I asked her about other symptoms he might have. Did he was he a tail walker? Did he have a sacral dimple? Was he, constipation? All of the things we saw, I was asking her those things, and he had all of those things. And so Annette, I said, you should maybe get him checked for a tethered cord. And she started researching tethered cord, and she was like, oh my God, he totally has this. They had the surgery. He walked for the first time in years. After the surgery, his seizure reduction was enormous, and his cognition improved. He's nonverbal, he was non-ambulatory at the time. So it was a huge difference. And so we started talking about, I wonder if the other KBG kids have this. And we did a little survey in the KBG group. We put it together based on symptoms. It's much more complicated than one that we do now. But it was kind of like, hey, what's going on here? And then we gathered all this data together, and we brought it to Petra. And to her credit, we weren't just two moms. We had some valuable information. And then we decided, hey, let's really do this and figure out if they're suffering, because, my daughter's had 29 surgeries, and I think the tethered cord surgery was really, her foot surgery was much, much worse. than the people hear that spinal cord surgery and they think, oh my God, it's going to be awful. I didn't have that experience. I don't know a lot of people that have had that experience, that it was, just a horrible recovery. I think we were in the hospital 4 or 5 days. But yeah, I mean, I imagine the younger you are, it's harder to, because you have to be, out for 24 hours. They can't move and just lying there. And so that's how I got involved. And then I, of course, started noticing, my eyes were open to this is so prevalent in rare diseases. And when I would see a disease that even had one of the symptoms, I would start researching that disease. And then talking to people, and then, they say, oh, we do have somebody that has a tethered cord. And so I said, wow, now we're around, I think we're at 30 possible tethered cord rare diseases. So Petra, Dr. Argwal, and I are putting together a research initiative to study this in rare diseases. So, I think there's no downside to this.
Right.
What it's done for the people that I know that have the surgery has been remarkable. And, sometimes there's retethering. I don't know anybody that's had any complications from surgical, the things that you were talking about. I know it's very, very low, but I just think it's so important. And, maybe my thinking is, if we can figure this out, why this is happening, maybe we can stop it or prevent it in the future. So.
Thank you. Yeah, Lisa, did you want to comment on some of the things that you have learned about it in the RASopathies community, and then we'll get to our question?
Yes, definitely conversations in our Costello syndrome listserv. There was a time when there was a lot of discussion. There was one mom whose child did have a tethered cord, and it was her path to diagnosis was really bumpy. And, going from the world-renowned local hospital in the big city to a smaller hospital where the orthopedist was more careful, also because the orthopedist had a tethered cord herself, so it's much more sensitive to it. And so yet we do have so many of those symptoms, the toe walking, the constipation, yeah, just a lot of things that could be just the syndrome, Costello syndrome, or it could be tethered cord. So it just, I think there's something to it. And I see in the chat also that Noonan syndrome could very well have issues. I wish we had somebody from CFC syndrome to talk about those families. Yes. So, do you want me to read that, Beth? I can read so we have in the chat, my son had an MRI of the spine, age 5 at the time, and it was reported that the conus terminated at L3 and that he has thin fatty infiltration of the phylum. When we saw the neurosurgeon, we were told it can't be tethered spinal cord syndrome causing his incontinence, because his urodynamic study was normal. We were also told a low termination of the conus is a normal finding in Noonan syndrome patients. So that gives me a little aha. And so the person is asking, would you agree with this conclusion? He's now 6 and still struggles with urinary incontinence and constipation. And another thing we do worry about is if there is that problem and it goes too long, then being able to learn how to have urinary continence is much harder. So
also sorry to interrupt. Also,
no,
what we like to say is, and that is, I'm glad this question came up, because sometimes the urodynamic study is normal. Tethered cord is not all about bladder and bowel, even though bladder and bowel are very important function, no question. But some people present more with the leg symptoms, with a neurological package, or more with just the orthopedic package, as Patricia Welton pointed out. So you often have to try it, of course, but some parts of it are just more prominent in a single person. And you cannot dismiss a patient based on little bladder symptoms and normal urodynamic findings if you have enough other evidence. That's why I want to promote the neurological exam as maybe even the more reliable biomarker than a urodynamic study. And even our population had, a portion of people had a normal study. So this is a misconception.
Thank you for that. Yeah, I was going to say if people in the community are faced with you know, thinking, oh gosh, my kid is having these symptoms and they're not getting any traction with their primary providers, what's the next best thing, or how do you advocate for getting the right specialists to look at your kid? Who do you recommend to go to first? Would it be an orthopedist or a neurological?
Sorry, can you
yeah.
repeat that question? Sorry, Beth.
Just if you suspect that you're seeing these kinds of symptoms in your child and your primary care physician isn't you know, able to help out, where do you recommend going first in terms of trying to get a specialist to take a closer look?
Yeah, well, certainly, you know, like eventually an MRI has to be done, and then it's a question of who is like really willing to order an MRI. It would still be a either a neurologist or a neurosurgeon with interest in or not interest, with understanding in tethered cord syndrome, because or an orthopedic surgeon. That is true, but sometimes if there isn't really like someone who is very much involved in seeing kids with tethered cord. For example, our orthopedic surgeon thinks of tethered cord all the time and has like understanding and would certainly refer patients to us if there is a concern. But that is, I guess, the rare scenario. So I'm afraid if you wanted to get it to the ground, you have to push for a neurologist or a pediatric neurologist or a pediatric neurosurgeon.
And how frequently does tethered cord is comorbid with scoliosis? Because my son has scoliosis, but I don't think he has any of these other symptoms.
Yeah, probably in 30%.
30%. Interesting. Yeah.
Yeah, but you have to understand, so that's based on our data, but don't understand, please understand, we also have like a good amount of like adult patients.
Mm-hmm.
And here it is a little bit harder to differentiate congenital scoliosis from like degenerative scoliosis. So sure. Probably the numbers are way higher in the pediatric population.
Well, I know it's been recognized in Noonan syndrome as well. Some of our clinicians have recognized it, and as Lisa mentioned before, that the vertebrae can, some of the children can have extra vertebrae or partial vertebrae, so it can be difficult, I think, to maybe initially identify the cause.
So what usually, you know, like one thing I like to add is if really things are hard to determine and you have a big problem to establish the diagnosis reliably, at the end, some sort of monitoring is not unreasonable. What I sometimes do is to see, like, let's see, you know, like, let's do some therapy and let's see how things evolve. And then after 6 months, I do another assessment. And then, for example, if the leg tone becomes more increased, or there is persistent pain despite physical measures, or other symptoms are progressing on a speed that shouldn't be a natural progression of the symptoms, then that should trigger like a concern of a neurological progression. And then it can be tethered cord. So sometimes you just have to, I hate to say it, have the evidence of progression in order to establish a neurological problem.
And do any of these signs and symptoms respond to anti-inflammatories, or?
Pain, of course, can respond to anti-inflammatories. True, because there might be as I said, some inflammatory component, but not to an extent that it would really be able to like change the quality of the function or the quality of life. It is more that physical therapy, but it has to be a very intense physical therapy, done very regularly and over, and also in expert hands, sometimes can change things more drastically, often for a short period of time. But I've seen patients, not so much kids, but adults that certainly elect to try everything they can physically to avoid any intervention, which is very reasonable. They manage themselves with physical therapy quite well, even though some limitations have to be accepted, but physical therapy can really help quite a bit.
Thank you.
It
Are there
sounds like a special kindness physical therapist, not.
Yeah, and yeah, I said manual therapy, or they say craniosacral therapy.
Oh,
Here in Rhode Island, and Patricia knows that we have like 2 physical therapists that are very knowledgeable, not only in connective tissue disorder treatment, but also in tethered cord. And they have a very specialized program for like fascial release and ligamentous release, even spinal fluid circulation, manipulation, which I don't have the depth of that, but yes, it's a very specialized treatment.
so that might be a challenge for private insurance or Medicaid to cover.
Yeah.
Okay.
I think that we're seeing the KBG syndrome since we were published, and it was established that, you know, there was a prevalence of tethered cord. You know, they're going to their doctors with that paper in their hand, and they're saying that, you know, this is not just me, my figment of my imagination, or, you know, this has already been established. We need to, it's at least, at the very least, something you need to consider. And we hope to
That's
do
good
that
news.
for other groups, because I mean, I just got lucky. You know, if you have Ehlers-Danlos syndrome, you need to be in Rhode Island. You know, we have Petra, you know, we have the physical therapists that are here. People come from all over the world for treatment here. And, you know, Dr. Chopra, and it's just amazing. But, you know, I know so many people with tethered cord that have been repeatedly told. I think Annette went to 3 different neurosurgeons before someone said, you know, and then you get into that doctor shopping side eye, you know, like,
Yep.
you know, like, wait a minute, what do you do? Why are you here again? So, you know, when I reached out to you, that was our hope. Was like, wow, let's make it easy on people to say, hey, this needs to be looked at when they go to a doctor that, and I think most, you know, when I think of tethered cord specialists and neurosurgeons, I think they're EDS specialists. You know, like they primarily are working on Ehlers-Danlos syndrome, tethered cord. But, you know, it just feels like, why suffer for years sometimes finding a doctor that might understand? I mean, I just got really, really lucky. We're so happy. And of course, Petra is the best.
I don't know
Yeah.
about that, Patricia, but I appreciate your kind words.
But my daughter loves Petra. Like, she was like, make sure you tell Petra I said hi. Oh, Dr. Klinger.
Please tell her I said hello too.
I want to be
Always.
cognizant of the time, but I wanted to quickly ask, since I was reading a little bit, browsing through some of the papers that you shared, is Chiari-1 malformation at all related to this, or something that you have to distinguish between with the symptoms?
Yeah, so it is related. First of all, you have to look at it the other way around. So basically in the Chiari-1 population, there's a high prevalence of tethered cord as well. So probably 25 or 30% with Chiari also have a tethered cord. And these 25 and 30% is actually radiographic positive tethered cord. So they have a lower lying conus and thickened filum terminale. People have always try to make up the not make up, but cite this traditional theory of the caudal traction, you know, that the phylum is kind of pulling everything down, including the cerebellum. That is very controversial, and even other experts don't know whether this is holding true anymore. So basically, this could be just like malformations that are connected embryologically, but they still have separate effects to the body, if that makes sense. So in the pediatric world, we would certainly favor treatment of tethered cord over the Chiari, but we still don't know how they are pathologically connected, and we still have to consider them separately.
I raised my hand because again, it was the families who brought it to the doctor's attention that our children with Costello syndrome can develop Chiari postnatally. So this was, I didn't know that was a big deal, but and I wonder if that also is part of the complexity of the potential for tethered cord.
Yeah, I would say certainly. So your question was if in Costello's there's also the observation of Chiari, and if that is a relation to tethered cord. Is that the question?
Well, also that it develops after birth. It's not something that.
Oh,
that's the key apparently to the uniqueness.
Yeah. So talking about like things that develop after birth, that is also true for tethered cord. So it's not always entirely a congenital problem. When I spoke to you about like the mechanical problems and the inflammation of the phylum and the stiffness, that certainly is something that can occur even, let's say, after any major impact to the spinal cord, where there is a shock that can cause an instant mechanical overuse of the phylum or mechanical stress to the phylum, where potentially, you know, the collagen can break down through those forces, or often through, you know, like inflammatory processes, almost like a tendinopathy, as I said, like a tendon that can also from overuse. So what I'm saying is certainly these circumstances might also develop after birth, and it might as well be in some genetic syndromes due to changes in the dynamics of the spine, due to totally neurologically unrelated issues. Tethered cord can develop secondary. So we have to understand the spine itself and the phylum. They work in a quite a systematic fashion. And the phylum, let me say, responds to changes in the dynamics of the spine. In our institution, we treat a lot of elderlies that started to have degenerative changes in the cervical spine or spinal stenosis in the lumbar spine. And then they also develop tethered cord symptoms. We then see that there's also like a thickened phylum, or sometimes we don't see it, but the symptoms can only be explained by a tethered cord situation. So yes, it can also develop based on any dynamic changes in the spine or the skeleton.
That's fascinating. Thank you.
Yeah, it really is. Thank you so much for joining us today. We're delighted that you were able to make time on a precious Sunday. And we think that this will be a really good resource for our community in the future to be able to view this and take a look. Let me see. We have one more question in the chat that you may want to respond to. But otherwise, I think we'll call it a wrap for today, and we can say thank you once again.
I'm just adding my email.
We can stop recording.
Yeah, I'm looking for the button. There it is. Thank you.
Excellent.